Okay, well, good afternoon, everybody, and welcome to Center for Practice Excellence Rounds. My name is Zubin Austin, and I will be your host for today. I am very pleased to introduce our speakers for today, Dr. Joyce Lee and Greta Ma. Their topic will be hospitalization prevention through telephone intervention in a geriatrics clinic for Parkinson's, a novel approach to a complex problem. And indeed, it does sound that way. Let me give you a little bit of background about our speakers. Dr. Joyce Lee is a specialist in the care of the elderly physician, specializing in comprehensive assessment and treatment of elderly patients with complex medical problems, especially Parkinson's disease and related disorders and dementia. She's the founder and the physician lead of the Geriatrics Clinic for Parkinson's at North York General Hospital, and she is also one of the co-founders of the 5-weekend Care of the Elderly certificate course at the University of Toronto, an annual course which has educated over 100 family physicians in Canada since its inception. Her research interests include dementia, medication use, and the management of Parkinson's disease in the elderly. Greta Ma is a board-certified geriatric pharmacist at North York General Hospital's Geriatric Clinic for Parkinson's and the Geriatric Day Hospital and coordinator of the Fanny Bernstein Living Well with Parkinson's program. She was the recipient of the CSHP Douglas J. Stewart Award and the North York General Professional Practice Award. She is currently an adjunct lecturer at the Leslie Dan Faculty of Pharmacy at the University of Toronto. We're very pleased you're both able to join us virtually for today's rounds, and thank you for what you're going to let us know about your program in the area. I'd also like to introduce at this time our discussant for today, who is live with us in the room here at the Faculty of Pharmacy. And our discussant is Chris Van Lund. Chris is a geriatric medicine pharmacist and clinical practice leader at Mount Sinai Hospital, as well as an adjunct lecturer at the Leslie Dan Faculty of Pharmacy here at the University of Toronto. After all that talk and all those introductions, it's my pleasure to turn it over to Joyce and Greta to help us better understand hospitalization prevention through telephone intervention in a geriatrics clinic for Parkinson's, a novel approach to a complex problem. Please join me in welcoming Joyce and Greta.
Thank you for having us. This is Joyce. So that's Greta's disclosures. I have no disclosures. Today, we're going to talk about the epidemiology of Parkinson's disease and why it's such a complex condition, as well as what the implications are for healthcare utilization. We'll outline some of the clinical challenges of advanced Parkinson's disease and introduce to you our innovative model of comprehensive Parkinson's care to deal with these complexities. We'll present you our research on hospitalization prevention for older patients with Parkinson's and highlight the pharmacist's role at the center of the Geriatric Clinic for Parkinson's. So 82% of persons with Parkinsonism are actually over 65 in Ontario. So Parkinson's is very much a disease of the elderly. It is the fastest growing neurological condition, surpassing Alzheimer's disease. The number is expected to double by 2030. So we're going to see many more patients with Parkinson's. It turns out that patients with Parkinson's are at a much higher risk for hospitalization. In this particular study, they looked at 3,500 people with Parkinson's disease, and 1 out of every 3 patients was hospitalized on history, and with a 50% readmission rate. Patients with Parkinson's also have a higher risk of longer hospitalization, in addition to a 1.5 times risk of being hospitalized. The main reasons for them being in hospital are psychosis, including hallucinations, delusions, and so forth, non-motor symptoms with Parkinson's, including low blood pressure, falls, constipation, and bladder symptoms, as well as motor complications. So what are the risk factors for readmission? Older age, when they're on more medications, when they have a higher number of comorbid conditions, and a higher level of caregiver stress. 40% of caregivers of Parkinson's patients report that their health and social life has suffered, and almost half of these caregivers had depression. We know that caregiver burden increases as the patient is suffering with increasing disability and Parkinson's symptoms, particularly the ones that are on the screen, including depression, psychosis, confusion, and dementia, and falls. So you notice that the things that increase caregiver burden and stress the most are actually mostly the non-motor symptoms rather than the motor symptoms of Parkinson's. So let's go through some basic pathophysiology of idiopathic Parkinson's disease. Parkinson's happens when this group of cells in the substantia nigra, or the black bodies in the basal ganglia, degenerate. By the time that the symptoms appear in terms of the typical Parkinson's symptoms of tremor, stiffness, and gait changes and slowness happen, 80% of the cells have already degenerated. In medicine, we call these symptoms the TRAP symptoms. Tremor, rigidity, akinesia or bradykinesia, meaning slow movement, and postural instability. Let's go through quickly the treatment options. I'm sure you're all familiar with these, but let's just go through them quickly. So the gold standard is, of course, levodopa, and levodopa is metabolized to dopamine. It's the most effective and most evidence-based medication. However, it does have a short half-life, especially in patients with more advanced Parkinson's. And then we have the dopamine agonists, including things like pramipexole, ropinirole, and rotigotine. These do have a longer half-life, but there are a lot of side effects. And these medications primarily mimic dopamine, and they're not actually the real thing. And then there are the MAO-B inhibitors, such as rasagiline, selegiline, and afinamide, and these block the metabolism of dopamine as a neurotransmitter. Entacapone is a COMT inhibitor, and it also blocks the metabolism of dopamine to extend its benefit. Amantadine is primarily used to reduce dyskinesia, which is involuntary body movements, such as what you may have seen happens with Michael J. Fox, usually with peak dose. So let's look at anticholinergics for a minute. Anticholinergics used to be prescribed for patients for tremor, but as we all know, there are many, many side effects, and therefore, we don't tend to use them in the elderly population. When we look at Parkinson's, when we talk about the motor symptoms of TRAP, we're really looking at the tip of the iceberg, because the disease affects so many different areas of the brain and also in the peripheral nervous system. All these other non-motor symptoms are actually just hiding under the surface, making this a very complex condition. You can see that the Lewy bodies, which is the pathologic basis of Parkinson's disease, is not actually only in the substantia nigra, but it actually affects your peripheral nerves, affects your cortex, and so on and so forth, leading to all these different non-motor symptoms. As the disease progresses, not only do we see the typical motor or physical symptoms of Parkinson's, but we start to see more and more depression, anxiety, and dementia, hallucinations, psychosis, as well as all the autonomic symptoms of hypotension, frequent urination, constipation, swallowing issues, and so forth. So I'll just illustrate some of these by using a case. So this gentleman, Jay, he's 72 years old, lives with his wife. He's had Parkinson's for 5 years. He's had 5 falls within a month and went to the emerge 3 times. He complains of postural dizziness, nausea, and some difficulty in concentrating and thinking. When he's falling, he's usually in the on state. So when someone's taking levodopa, there's typically the on and the off state. On being when the medication is working and they're able to move with ease, and off being when the medication is wearing off and some of the TRAP symptoms are returning. So you can see that the blood pressure of this patient drops substantially from sitting to standing without a change in the heart rate. This is a sign of autonomic dysfunction. We know that in patients without Parkinson's, normally our blood pressure tends to drop when we're sleeping. However, there's a reversal in circadian rhythm when someone has autonomic dysfunction, in that the blood pressure tends to be lower during the day, and they can have supine hypertension when they're lying down to sleep. Of course, we know that a lot of medications can induce hypotension. Now, the list includes alpha blockers for BPH, anti-Parkinson's meds that we talked about. Actually, most of them do increase hypotension. Antihypertensives, of course, antidepressants, especially tricyclic antidepressants, antipsychotics, and a various number of medications, including PDE5 inhibitors such as sildenafil, and also alcohol. So we try to manage this problem first, non-pharmacologically. First of all, we have to educate the patient about their triggers. Big meals can divert the blood flow to the gut, to the splanchnic circulation, thus contributing to postprandial hypotension. Forceful defecation, so constipation can be a risk factor, dehydration, heat, and so forth. And they have to be aware of the symptoms and how to monitor their postural blood pressures. The ways to manage it is by increasing blood volume, by increasing fluid intake, and also adding more salt into the diet. So sometimes we tell people to take more V8 or broth or even sodium tablets. We can decrease the venous pooling in the lower extremities by elevation of the legs using compression stockings, which a lot of people don't comply with because compression stockings are quite difficult to wear. But we've had more success with actually abdominal binders that compress the splanchnic circulation to reduce the hypotension. Raising the head of the bed by 4 inches can also reduce nocturia and supine hypertension as well. In terms of the medications used to manage orthostatic hypotension, we use midodrine, which is an alpha agonist. The main thing is that we need to tell the patient to avoid lying down for 4 hours, and the last dose should not be any later than around 4 p.m. to prevent supine hypertension. Fludrocortisone, of course, is a steroid neuralocorticoid, and it causes volume expansion by retention of sodium. We need to monitor electrolytes to make sure that the patient does not develop hypokalemia and also edema. And if the patient does have supine hypertension, we might need a small dose of a short-acting type of antihypertensive like captopril at bedtime. Pyridostigmine can have a modest vasoconstrictive effect without worsening supine hypertension, but oftentimes it is not sufficient to deal with very severe orthostatic hypotension. So this is the list of medications that Jay is taking. You see he's taking rasagiline, Stalevo, and Sinemet CR. Stalevo is, of course, the combination of Sinemet or levodopa, carbidopa, and entacapone. So first of all, when we see that the patient's on tamsulosin, we can see, well, can we reduce the tamsulosin to 0.4 milligrams to reduce the risk of hypotension? And also, we can reduce rasagiline to 0.5 milligrams daily before adding midodrine 3 times a day to see if that's necessary. A few years later, Jay has developed some new symptoms. He's got minor and benign hallucinations becoming disturbing and very scary over time. Oops. Let me make this play. Okay, there.
I'm Diane Sagan. I live with my husband and 9, and after a little while I began noticing he would talk about seeing things on the periphery of his vision. He began seeing black cats, and they would kind of run past him. At that point we thought, oh my gosh, what is going on? When Jay began having hallucinations and delusions, we went to his neurologist and explained what was going on. And he explained to us that this is an aspect of Parkinson's disease psychosis. There are so many things that go along with it. Definitely there's a paranoia. He gets worried that somebody's accessing our money through the computer. That's not me. He also doesn't believe that I'm me very often. He will walk up to me and say, "Where's Diane?" And he will say, "Can you please call Diane and let her know I want to talk to her?" And so I'll call myself and he'll talk to me, and strangely we can have fun with that. It's not all bleak, but it's kind of scary. You just wonder how far it will go. Day-to-day life has changed immensely. The physical things with the Parkinson's are easier to deal with than the psychosis. We both were forced to retire, and I basically need to be with him 24 hours a day.
So you can see that something like psychosis, as opposed to the motor symptoms, are actually can be much more disabling and cause a lot more caregiver stress compared to what we think of as Parkinson's symptoms like the tremor, the stiffness, and so on. So the approach to PD psychosis is you need to rule out potential causes of delirium, such as acute infections, illness, constipation, fecal impaction, urinary issues, etc., etc. And also, the pharmacist can help with doing a detailed medication review. Can any medication be contributing to the psychosis, such as anticholinergics, benzos, narcotics, and so on and so forth? So we know that all Parkinson's medications can potentially worsen psychosis. So there is generally sort of an approach that we use in terms of which medication to stop or to decrease first. First, we'll try to stop and taper down anticholinergics. And we know that for amantadine, because it has anticholinergic properties, we also try to taper that down. We need to taper down the dopamine agonist. It is important to know that dopamine agonists cannot be stopped abruptly because there's something called dopamine agonist withdrawal syndrome, which is very difficult to treat and doesn't respond to levodopa very well. And then next is decreasing or stopping rasagiline or the other MAOB inhibitor or entacapone. And gradually, if it is still necessary, if the patient is only on levodopa at this point and they're still psychotic and seemingly overtreated, then we need to decrease levodopa very gradually. This is the last resort. And of course, with any of these changes, we need to monitor for worsening of motor symptoms. So it's important to be able to look at the patient as a whole and set goals as to, how do we balance the cognitive function with the motor function. Parkinson's disease dementia is important to note because 80% of patients can develop it by 8 years and about 50% by year 4 to 5. So whenever someone has PD psychosis, we must always keep it in mind that we need to assess to see if the patient actually has underlying Parkinson's disease dementia. The first line treatment is a cholinesterase inhibitor such as donepezil and rivastigmine, and antipsychotics such as quetiapine can only be used very judiciously and really should not be the knee-jerk reflex to psychosis in Parkinson's. We know that in terms of antipsychotics, the only ones that are recommended in the guidelines right now are quetiapine and clozapine because these are the ones that do not worsen the motor function. And all the other ones, including risperidone, olanzapine, aripiprazole, and so forth, are not recommended. And of course, the typical ones, like haloperidol, are contraindicated. So for Jay having PD psychosis, his MMSE was 20/30. And you can see that he's on rasagiline, Stalevo, and Sinemet. So we can first try to discontinue rasagiline and see if that can reduce his psychosis sufficiently. If necessary, we can stop the entacapone portion by converting Stalevo gradually back to levodopa at each dose. And we don't generally tend to touch the low-dose Sinemet CR because that helps the patient overnight in terms of their symptoms. And if that still doesn't work, we can certainly give them a small dose of quetiapine PRN and also consider adding a cholinesterase inhibitor. So you can see how advanced Parkinson's disease is really like a geriatric syndrome that requires geriatrics management and not just a traditional neurological approach that we're all used to. In fact, the British Geriatrics Society is quite into managing Parkinson's, and they have stated the management of Parkinson's disease in elderly patients is made much more challenging by the common occurrence of comorbidity, both physical and psychiatric, and the associated polypharmacy increases the potential for interactions and adverse effects. Okay, 1 second. Our slide is stuck. Okay, there. Okay. So the geriatric syndrome of Parkinson's disease really requires a comprehensive geriatrics assessment. In fact, the BGS recommends a full medical assessment by specialists in geriatric medicine and comprehensive service providing outpatient clinic, day hospital, inpatient assessment and rehab and long-term care in an interprofessional manner is often required. And British Geriatric Society also has a Parkinson's Disease Academy and has run 9 formal classes, master classes for geriatricians already. And in the NICE 2017 Parkinson's guidelines, we know that the specialists providing care for Parkinson's in the UK actually include geriatricians and neurologists supported by the interprofessional team. So this is quite different from what is happening in North America right now. So I have to ask then, given all this information, is it time to rethink of PD as a geriatric syndrome and to really involve more geriatricians in the caring for these patients? Right now, we're seeing in North America, a Parkinson's patient goes to the family doctor, gets referred to the neurologist or movement disorder specialist, and then if they have any depression or psychosis, they get referred to a psychiatrist. If they have any urinary issues, they get referred to a urologist, and maybe if they have cardiac issues, to a cardiologist, and so on and so forth. So in general, a lot of these specialists work in silos, and it results in very fragmented care. And there's often a lack of holistic interprofessional team approach to dealing with the problem. And this causes a lot of caregiver stress because the caregiver doesn't know who to call when something happens. And this is one of the main contributors to caregiver burden. This is a new guideline for the Canadian guidelines for Parkinson's disease that just came out a couple of months ago. And it advocates for an interprofessional team approach in developing a tailored individual care plan tailored to unique needs of each individual to maintain their quality of life. And it states and emphasizes that no primary care physician or neurologist can meet all the needs of those with Parkinson's. So we really need to all work together in a team to help these patients. And also it states that people with Parkinson's should have regular access to clinical monitoring and medication adjustment and a continuous point of contact for support. At Norfolk General Hospital, we noticed the need of these Parkinson's patients, and we started the Geriatric Clinic for Parkinson's, which offers comprehensive Parkinson's care since 2007. And our service is complemented by the Living Well with Parkinson's Exercise and Education Program, which is an 8-week education and exercise program for early Parkinson's patients and their caregivers, and the Geriatrics Day Hospital, which is an outpatient rehab program for the later patients. So you can see that our team, which comprises a physician, pharmacist within our clinic, and as well as in the day hospital and Living Well program, we've got social worker, speech language pathologist, dietitian, nurse, mental health nurse, OT, and physiotherapy. We form a team that surrounds the patient and caregiver to provide the care. So in summary, in terms of what is comprehensive Parkinson's assessment, we focus on all the aspects of the person, including motor symptoms, which can comprise the TRAP symptoms, osteoporosis, falls risk, and so forth, the neuropsychiatric issues such as depression, anxiety, psychosis, dementia, sleep issues, and all the autonomic symptoms, including gastrointestinal symptoms, hypotension, urinary symptoms, and swallowing difficulty. So our assessment each time will look at all 3 areas for the patient. Since the inception in 2007, about 1,500 patients have been served in our clinic. And we also have our certified geriatric pharmacist with National Parkinson Foundation certification, Greta here, who provides a telephone intervention service Monday to Friday during office hours. And Greta also meets and assesses every single patient that comes in through the clinic. And I'm a care of the elderly physician so my background is in managing geriatrics patients, and I've done 6 years of training with a Parkinson's specialist. So therefore, I'm kind of combining the geriatrics piece with the neurology piece. So now I'm going to pass this on to Greta.
Hi, everyone. So I just want to go over a little bit about our research and how it evolved, becoming a research. It actually started off like my workload measurement. I just feel that my day go by so fast, answering different phone calls from patients who saw it as a clinic, and they always come up with questions about medications or symptoms. So this is the best way that to design a prospective observational study. We know it's not ethical to have a randomized control trial, but we just want to capture the impact of this telephone intervention. So when we first designed this study, we're thinking about having a neurologist in the movement disorder clinic who knows Dr. Lee very well and be able to help us to assess whether this is a very important, significant intervention or not. But she actually gave us a very good idea. Like, why don't we ask patient if this problem is not resolved, would you bring the client or patient to the emergency room? So that's how we design our study. So basically, it's a prospective design. Anytime when I get a phone call, I'll document what's the issue and also have a follow-up within a week and see if patients end up going to emerge and ask the caregiver, would you bring your mom or dad to emerge, like if the problem is not resolved. And we also want to get anonymous feedback from the person who called if they're satisfied with the service and how confident they are. So we have our research assistant to provide this anonymous survey. So if any student who would like to help us with research, we'd be glad to recruit students. Okay, so in terms of our outcome, over 1 year, we received 337 calls from 114 patients. And as you see, the ratio is almost like one patient would require like about 3 calls. And majority of the calls are from caregiver and most are spouses. So you can imagine like the patients are pretty old, average age is 80. So even their spouse are not that young. Um, so you imagine the type of conversation we have over the phone is not that easy. The duration of call is about 19 minutes, and most of the medical comorbidities involve like dementia and anxiety. So a lot of time, these patients are very frail, and they can have both dementia and mood disorders at the same time. The number of medication is close to 11 medication, and you can see how frail they are. And the Unified Parkinson's Disease Rating Scale is also very high. The higher the number it is, the more severe physically. So over 18 to 20 points, they're starting to have a lot of mobility issue. Duration of Parkinson's is 9 years. So as you see, they're quite advanced. So in terms of the diagnosis, not all the patients come to a clinic have idiopathic Parkinson's. In fact, idiopathic Parkinson's is the easiest to manage. When we have atypical Parkinsonism, such as MSA, patient will have like huge drop in blood pressure, passing out easily, and also patient with progressive supranuclear palsy or cortical basal degeneration. These are very fast advancing type of Parkinsonism that they require lots of help or even going to nursing home within a few years. On top, we also have quite a number of people with dementia, Lewy body, and we see a lot of these patients in our practice because we see a lot of elderly. The older they are, they're still at higher risk of this type of dementia with lots of hallucination and psychosis. So the reason for these phone calls, majority actually is non-physical symptoms, such as just like the case we talk about with Jay, low blood pressure, psychosis, dementia, and a lot of time they have mood disorder, trouble sleeping, anxiety. And also from our data, we found a lot of people call us, especially if the patient is very anxious. And these are the ones that tend to go to emerge a lot, reporting with heart palpitation, shortness of breath. It turns out it's just anxiety. Adverse drug effect is also high, and compared to other type of telephone intervention not done by pharmacists, usually the adverse drug effect is not recognized as easily. So I think having a pharmacist to do this type of intervention, we can capture a lot more adverse drug effect and get it resolved. And some of the cases, including bruxism from SSRI, I have a patient couldn't eat just because of the spasm of the face from SSRI. So things that we don't usually see, but we come across. and of course psychosis, dizziness, a lot of these CNS side effects from Parkinson medication are very common. Of course, motor symptoms with fluctuation, so on and off, and also the delay on they take the pill is not working, or of course they need to gradually have requirement for higher dose as the progression of Parkinson's occur over time. We have a lot of drug information questions. They often want to know, oh, they hear about this new drug, is it going to help? Or clarify the timing of the medication. And referral for different services, especially the home care service or even wound care sometimes. They have a fall and they need help. So these are the issues that I come across a lot. So 98% of these calls were resolved without going to emerge, and 93% resolved like with the telephone advice or prescription. So sometimes we may have to get patient to see the family doctor earlier, something we suspect may be a UTI, or as I mentioned, the wound care, we have to get the GP involved, or sometimes we need to get patient come back to see Dr. Lee at our clinic. And only 7 patients out of all these calls end up going to emerge. So it's about 1 in 4 calls indicates this is a crisis call. So if the problem is not resolved, the patient will have to go to emerge according to the caller. So for the crisis call, we also break it down to the reason. And again, we see the same pattern: non-motor symptoms, adverse drug effect, and also the motor fluctuation. So as I mentioned to you earlier, psychosis, hypotension is huge. Pain, when they have pain during the off period, is the very serious neuropathic pain that's very disturbing. And of course, mood, anxiety, depression. And we have one case of constipation. Constipation is very common among people with Parkinson's, and sometimes they even have bowel obstruction, leading to requirement for surgery. So timely telephone interventions prevented emerge visit in 93% of the crisis call. So this is very significant. So the key findings, our patients are very frail. As I mentioned, they're on many different medications. And as you notice, as the disease progresses, they accumulate more non-motor symptoms. And we start off with just a little bit of low blood pressure, and then gradually, as the cognitive decline, they start to have dementia. And over time, Parkinson's drug need to be increased. So all these little problems begin to accumulate. So not surprisingly to see they're on so many different medications. So from our anonymous survey, we found 97% is satisfied with this telephone intervention service, and 92% have high confidence in our service. And I think they know that we have complete history of each client, because we take all the medication and we do a whole list of medical condition. So when they call, we immediately know what concern they usually have. And as you notice, I got a few calls that's not even related to Parkinson's. So the main reason for call is non-motor symptoms and adverse drug effects and motor fluctuation. So the role of pharmacists at this clinic is huge, and I really want our next generation student to acquire more skill in terms of geriatric, and also learn more about Parkinson's. As Dr. Lee mentioned earlier, the number of people will be doubled by 2030. And right now, if we try to get a patient go to the movement disorders clinic in Toronto Western, the wait time is 2 years, and patient really cannot wait. And that's why geriatric has great potential to help people in the community. And we recently recruited our Norfolk General neurologist and a nurse to help us in the clinic as well, to be more collaborative, and also to expand this geriatric model. So the role of pharmacists are definitely the initial appointment for any new patient. I'll do a BPMH and get rec and find out what drug the patient is taking and for what condition. So we get all the notes from the referral physician as well as the family doctor, and we screen for medication that might have induced Parkinsonism. For example, someone on metoclopramide and starting to have symptoms, or maybe this history using antipsychotic. And we also screen for any motor fluctuation, give them a timetable, and they can record like what time they experience the off period. And as a pharmacist, I start to wear a different hat. I would check patients' blood pressure. I would do MMSE or MOCA to check on the cognition. And I would do a GDS to assess the depression or the back anxiety index. So a lot of these screening tools I'd be able to provide. And by the time patients see the doctor, we have a pretty good idea what's the main problem. And also, it's important for pharmacists to identify if patients are taking medication on a regular basis, especially for those who have cognitive impairment. They will have trouble even remembering what time to take the medication. We know Cinemat has such a short half-life and need to be dosed like every 3-4 times a day. So identifying drug therapeutic problems and drug interaction is crucial, and we'll be able to screen for drug that lower blood pressure or drug that's have anticholinergic burden load. So pharmacist has a huge role in the area of helping people with Parkinson's. And of course, the easy telephone access is very important to reduce caregiver burden. And if you remember, the caregiver burden actually high connection to hospital admission and readmission. So just a slide about many different drugs can induce Parkinsonism, and pharmacists screen a lot of these medications. And this is the tool we use, asking patients to check off anything that could be a concern, and all these symptoms are related to Parkinson's. And a lot of time, patient or caregiver may not be aware, and they realize, oh, I didn't know constipation is related to Parkinson's. And Parkinson drugs has a lot of side effects. Dopamine agonists, especially, cause hallucination in elderly patients, and the impulse control disorder can be hypersexuality or binge eating, shopping, or even day-to-day activity. They become so impulsive. And also, as Dr. Lee mentioned, we cannot suddenly stop the drug. They can get into withdrawal. Amantadine is another drug causes a lot of nasty side effects, confusion, hallucination in elderly. We try not to use it unless the dyskinesia is really disturbing. The other issue we deal with a lot is drug interaction. We tend to use a lot of MAOB inhibitor, but when pharmacists dispense medication, they check Lexicon, for example, and they found, oh, this is the absolute contraindication, then patients shouldn't be getting this medication. But the latest results actually indicates this is only a theoretical drug interaction because MAOB inhibitor is extremely selective, unlike the MAOA inhibitor. So the chance of increasing serotonin when using SSRI at the same time is very unlikely to cause serotonin syndrome. So even the drug study for Resergiline, they allow patients to be on antidepressants. And the recent Staccato study done by Jack Kent, he's the guru pharmacist in Parkinson's, and they found this study is really just a theoretical drug interaction. It's not a contraindication. So since then, they changed the product monograph. So these are the drug interaction questions that I come across a lot. Now, having said that, if the patient is on SSRI plus trazodone for sleep and having the maximum dose of Resergiline, and they may still be at risk. So it's all dose related. So we have to monitor the dose of the SSRI. So it has to be individualized. So when I see this picture, that remind me of one of the patients called me in a panic mode. He has underlying anxiety disorder, and he called me, say, the whole morning I couldn't move. I took my medication. Then I find out he actually woke up late that morning. He didn't take his pill, but he's so hungry. So he ate a full breakfast. So he had his bacon and egg. And that's why the whole morning, the levodopa wasn't working. So levodopa is absorbed in the small bowel, not in the stomach, and also require the special transporter to carry the molecule over to be absorbed. So if there's any amino acid from protein, that can cause competition. So food or high protein diet can affect the absorption. So I just explained to the patient, I said, don't worry, your drug will eventually work. And I'm so glad that he listened. He didn't go to emerge, and he felt so much better after. And from that lesson, he always remember to take levodopa on empty stomach and wait at least half an hour before he eats breakfast. Now, the other fluctuation for motor symptom is the wearing off. So as Dr. Lee mentioned, over time, our brain cells is no longer producing dopamine in the situation of Parkinson's disease. So initially, they still have some reserve. So if they forget to take the levodopa, they felt fine. But over time, we find the levodopa only lasts shorter and shorter. It's not because of the levodopa doesn't work. It's basically the neurons are no longer producing enough dopamine, and eventually the drug level of levodopa reflects the on and off. So patients struggles a lot, and over time we have to modify the dosing schedule to even every 2 hours for each dose of levodopa. So the role of pharmacist is really huge in the area of Parkinson's, and I did a poster a few years back in PPC and highlight different type of drug therapeutic problems, and the problems that require drug therapy is the biggest, and followed by non-adherence and ADRs. And in terms of conditions that require treatment, definitely a lot of dementia, mood disorder, constipation, dizziness, and pain. So the success factor for our model is comprehensive approach to manage Parkinson's, and having a physician who totally understand medication, because Dr. Lee was a pharmacist, graduate from our faculty before he came to medical school. So he knows exactly what pharmacists can accomplish. And also the way we think about medication management is very much in sync. So we're spreading this model to other area. We just present to our GP and share some of the uh, joy we have serving this population. Thank you.
Well, thank you very much for that presentation. I suspect that many of us who are not specializing in geriatrics or have your experience, we learned a lot of really important things that I'm sorry I didn't know earlier in terms of just the complexity of Parkinson's, recognizing the importance of the non-motor symptoms, and your holistic approach to a patient rather than simply trying to treat a disease is really a model for so many of us. I'd like to turn it over now to our discussant for today, Chris Van Lunn. Chris is a geriatric medicine pharmacist and the clinical practice leader at Mount Sinai Hospital, as well as an adjunct lecturer here at the Faculty of Pharmacy. I'll ask Chris to provide some initial reflections on the presentation and then to pose our speakers a few questions about what they've actually done. Chris.
Thank you, Joyce and Greta, for providing a very comprehensive overview of not only just Parkinson's disease, but a very interesting new research project on a very interesting model of care that has a lot of potential benefits. There's a lot of themes that I got out of this presentation, and I just wanted to pass on several of them. Firstly, when you think about Parkinson's, as you mentioned, that it's such a fast growing neurological disease that's keeping pace or outpacing Alzheimer's disease, it's also fascinating to know that almost 50% of all Parkinson's patients will develop psychosis symptoms. and that up to 40% of the triggers of psychosis can actually be drug therapy or drugs that the patients are exposed to. So it's actually a good opportunity for pharmacists to play an important role both in community and hospital practice if they have the expertise. I wanted to mention, and I don't know if it was part of the introduction, that Greta is part of the Parkinson Society Medical Advisory Committee and was at the guideline development earlier, and along with Tejal Patel from the University of Waterloo. And so there's 2 pharmacists that are actually part of guideline development that have shown their expertise. And both Joyce and Greta have done a lot in terms of extra training, credentialing to really showcase the benefits of not only geriatric care, but specializing in Parkinson's and a complex disease state. In terms of hospitalization, I think one of the things that we always have to appreciate is that older people are particularly vulnerable to the risks of iatrogenesis. That is like unintended harm from the hospitalization and functional decline. And it's quite complex, but the pathogenesis of functional and cognitive decline likely involves an interaction between the actual aging process, the comorbidities that people often have in addition to the acute illness that patients present with, and the hospitalization process. And there's a lot of consequences of hospitalization of patients with Parkinson's disease, not only just the fact that they're at higher risk for delirium, immobilization, but also some of the unintended consequences include like bad medication adherence due to hospital policies about medication administration times, and that sometimes our admin times are not congruent with how patients get their effects from their Sinemet or their levodopa, carbidopa, and we have unintended harms from that. They get exposed to contraindicated drugs like the haloperidol that Greta and Joyce mentioned, the polypharmacy, and those also risk factors for increased risk of institutionalization after a hospitalization event. And so there's a lot of potential prevention work that really rings true in this session. And that's why I think where that old adage, an ounce of prevention leads to a pound of cure, is really crucial to think about. And the need for elder-friendly care really includes prevention of hospitalization. And I think it really triggers a paradigm shift of our care approach. It means that we have to individualize our care using an interprofessional holistic team approach and avoid working in silos, just as both of you have demonstrated. I also wanted to comment briefly on caregiving and the caregiving burden. I appreciate how you talked about that in your session on the overview of Parkinson's, but also in the research or workload that you talked about in terms of the telephone intervention. I think the data shows right now that the Canadian workforce, more than a third of the Canadian workforce is actually caregivers, informally caregiving for either a younger child, someone who's disabled, or an older adult or older loved one. And I think it's most of us can experience not only online or on the room that it's actually a big balancing act to manage not only your own employment, but caregiving responsibilities, absenteeism from work, and it can also lead to negative health outcomes for spouses, children, or family or friends who find themselves caring for a loved one. And it's actually a stressful position for caregivers to find themselves in. We often expect caregivers to carry out complex tasks, like managing complex medication regimens, dealing with challenging behaviors, and being navigators and advocates for fragile people. And so this telephone intervention really fills a gap. We know that also caregiving for someone who has dementia is similar to a chronic stress experience, and that it's associated with various poor outcomes, not only for the caregiver, namely depression and other health outcomes, but also for the patient receiving the care. In that we know that older persons who receive care from a highly stressed caregiver is more likely to be institutionalized or have worsening of their behavioral and psychological symptoms of dementia. The other theme I just wanted to comment on was about the intervention. I would probably say that this is quite a complex, moderately complex intervention. And we're always trying to figure out, like, what is the secret sauce? Because I know it sounds very simple from Greta's mind, but oftentimes a lot of effective interventions in geriatrics usually are complex and multifaceted. And so it requires a lot of substantial effort to develop, implement, and sustain. I think when I put on my quality improvement and patient safety hat on when I reflect on scalability and implementation, there's a few questions I would ask myself. And what is the problem common? Is it how common is it and how serious it is? And I'd say yes. Is the effective solution fairly easy to implement? And I'd say maybe. I don't know for sure. And then will solving this problem help with anything else? And I'd say potentially yes. And so a few years ago, there's actually a systematic review of interventions to reduce hospitalization of Parkinson's disease patients. There's not a lot of robust evidence out there for measures aimed at preventing hospital admission, but there's some retrospective studies that looked at an association between frequent neurological or neurology consults, open access clinics, ensuring medication compliance with a reduction in PD hospital admissions and ER visits. But the closest example I could see similar to this study or this research project that was just recently published in JAMA 2019 in September is called the Care Ecosystem Study. And what they looked at was a similar model focused specifically on persons with dementia and caregivers whose quality of life could be improved and whose preventable hospitalization could be reduced through caregiver support, linkages to community-based resources, care planning, and coordination. And the intervention, somewhat similar, a little bit more intense though. They had a care team navigator who did a lot of the telephone-based collaborative dementia care phone calls with weekly case reviews with an advanced practice nurse and a social worker, as well as a pharmacist. And the pharmacist had to do a lot of what Greta was doing in terms of reviewing all the medications, doing a BPMH and a med reconciliation, but also looking at what was affecting the caregiver's quality of life and the patient themselves. And so the outcome actually reduced, in terms of the primary outcome, in terms of quality of life, it was actually improved compared to usual care. And in terms of secondary outcomes, in terms of emerged department visits or use and caregiver depression and burden, there was a clinically and statistically significant improvement from those outcomes. And so it's very similar. The last thing I want to comment on is in terms of expertise and opportunities for education. I think this demonstrates that improving care for Canadian older adults will undoubtedly require educating and engaging the entire healthcare workforce. There was a US survey in the early 2000s that revealed that all responding pharmacy schools had some geriatrics education in their curriculum at that time. But the extent of such training was not commensurate with the growing population, the growing older adult population, unfortunately. And I think it's still similar in Canada. Clinical competencies, especially when we're dealing with particular populations such as older adults who are frail, are not always assessed in experiential learning nor in licensure exams. The lead for the Ontario Provincial Senior Strategy, Dr. Samira Sinha, who's based at Sana Health and UHN, actually made it clear many years ago when the strategy came out about the geriatric competence of the province's healthcare workforce. The fact that we don't require any of our health professional schools in Ontario to formally teach content related to caring for older adults is concerning. And so when they released the strategy in 2012, one key recommendation that came out in terms of education was actually the Ministry of Health should collaborate with the Ministry of Training, colleges, and universities to require core training programs to include relevant content and clinical training opportunities in geriatrics. In addition, the American ACCP actually developed a recent curriculum update or toolkit in terms of providing guidance to pharmacy schools in developing and maintaining and modifying their curricula. And the impact of pharmacists' involvement in medication therapy, as demonstrated by what Greta has shown, was considered in determining which topics to include in the updated pharmacotherapy toolkit. And I want to take it as an example, even if when you think about Parkinson's disease outside of geriatrics, it is a chronic disease for patients with ongoing medication therapy management needs. Students should receive education and training in it, but it is expected that additional knowledge and skills may be required to prepare graduates to prepare and to provide collaborative, comprehensive care for patients with this level of complexity. I think when I reflect back on one of Zubin's favorite topics in terms of clinical competency, and the pyramid or framework sort of analogy of nose, knows how, and shows, knowledge and competence forms the base of that pyramid. But if the goal is to graduate pharmacists who use their medication therapy expertise to benefit patients and the population in general, this foundation is actually absent in a majority of the graduates at the Faculty of Pharmacy at U of T. Right now, Parkinson's disease is a core topic only in the selective older adults course. It's not available in any of the pharmacotherapy or MTM current courses, as to what I understand. And so discrepancies need to be identified, and this provides an opportunity for curriculum changes and updates, because curriculum needs to actually evolve to address chronic disease frequency, socioeconomic burden as demonstrated by the caregiver burden that patients and their caregivers experience, and also the impact the pharmacist is involved in terms of medication therapy management. And I think I'll leave it at there for questions.
Well, thank you very much for your insightful comments and reflections as a geriatric pharmacist yourself, Chris. We have about a minute or two left if anybody in the room has any questions, or if anybody online has any questions. Just leave just a few moments for that.
Yeah, I'll just prompt them as well.
Yeah. You've certainly given us a lot to think about. And I think for many of us who are not specialists in this area, you've certainly given us a lot of new information, and unfortunately it's new information around what Parkinson's disease actually is, and conceptualizing it as a geriatric syndrome as opposed to a specific illness, I think is a really powerful way of thinking about it, and a powerful way of reshaping the delivery of care in an area of increasing importance. Annalise, any questions from members online?
Not yet.
Okay. Hearing none, I will say thank you all. Oh, sorry, we do have one question.
Sorry, it's Chris again for Joyce and Greta. Since the new Parkinson's guidelines were just released in September, I did have one question that one component of medication therapy management did stand out that's fairly new. There was, in terms of orthostatic hypotension management, domperidone was mentioned as a possible option. Could you provide comment on that?
This is Joyce. So domperidone, really, we haven't found it too effective in our practice. We see some neurologists using domperidone when they prescribe levodopa to try and block the sort of peripheral effects of dopamine, but in our experience, it has not been that effective. So therefore, we didn't really mention it in our pharmacological options.
We tend to use it for people who have nausea and trying to minimize those GI symptoms, improve motility. But in terms of blood pressure, it doesn't seem to be that effective. But I know in literature, they mention it, like theoretically, it helps, but in clinical practice, not really. And we worry about the QT prolongation, like if patients on quetiapine and other drugs.
And domperidone, in terms of using for upper GI indication, it really only affects the upper GI, sort of like dysmotility, doesn't help with constipation or lower GI stuff at all. And there's also some degree of tachyphylaxis, so it's so sorry, there's a bird chirping outside, but anyway. So we do use it occasionally at low dose for patients who complain of things like delayed onset of their levodopa. We find it most useful in that scenario.
And one from online. So this question's just from Connie Sellers online. She says, how is the family physician kept in the loop with your intervention?
So when the patient comes to see us at the clinic, Dr. Lee's notes will be automatically sent to them through dictation, through the hospital dictation. And if any telephone interventions through me, so usually how the chain of command works is like I talk to the patient, identify what the issue is, and then I quickly email Dr. Lee, and then she emailed me back. We both feel like certain way of will be the best management. Then I'll contact the pharmacy for a verbal prescription from Dr. Joyce Lee, and then I'll quickly cut and paste from my email what the issue is, and then I'll fax it to the GP. So the GP is in the loop of what's going on too. And sometimes if we need the patient to come back to see us early in the clinic, I will expedite that. So it's like an open door policy.
Thank you very much, and thank you to all who attended online and in person, and a big round of applause for Dr. Lee, for Greta, and for Chris for being our presenters and discussing today.
Thank you.
Happy holidays.
And also what
Look forward to hearing you and seeing you at our next CPE rounds in January. Thank you very much.